So one step is trying to understand what the determinants of behaviors are, what are the potential levers that we can influence around that. The next issue is how do we develop and optimize our implementation programs. I have a colleague, Martin Eccles, who has a great slide that says the way we normally do this is using the ISGLIAT principle. Anyone heard of the ISGLIAT principle? It stands for it seemed like a good idea at the time. In other words, even if we've done the diagnostic stuff, we sit around a table and sort of say, well, yeah, I think we should try this, or we should do that, or that worked over here, or probably work over here. And we're not, I think, being very critical and forcing ourselves to be explicit about the assumptions we are using when we're building our interventions. And I think what we need to do, both to develop the science, but also I think to improve the programs, is try and be much more reflective in what we're doing and make any assumptions we have much more explicit. And so there are a range of approaches. Intervention mapping has been used a lot in health promotion, which really asks you to specify what your target of your intervention is, what the behavior change or what the technique is that you're trying to deliver that with, and the particular content of the area. We've used this but adopted it to or hopefully to a much more sort of implementation science sort of perspective, where we use the theoretical domains framework to identify what the key domains were. We then would have an issue or identify in a matrix what the domain was we're trying to change, what the particular belief we were trying to change, and that helped guide our choice of behavior change techniques. So if you want to change someone's knowledge, you'll use a different behavior change technique than if you want to change someone's skills. And so starting to parse this out makes you think very clearly about what do we think we're trying to change here, and what's the justification for using this. When I was a family doc, I never could get the idea of how you injected the shoulder. And no matter how many times I looked at diagrams telling me how to inject a shoulder, never helped me. And so by trying to get people to be explicit about what you're trying to change, and then think about the technique you're using as a mediating pathway, I think it will help us have a much better sense about why we're putting together our interventions and what makes them hopefully successful. Final thing is, or probably no, not quite the final area, but the next area is evaluating then the effectiveness and efficiency of implementation programs. I think I come from a trialist background, and I believe that randomized controlled trials in general provide the most robust evidence about how we, across populations of professionals, healthcare settings, healthcare organizations, can lead to improvements in the quality of care that you've got. There are other people who would actually dispute that, and very happy to have that kind of conversation. My argument about why we need to have rigorous quantitative evaluation is exactly why we do them in patients. In general, the effects that we're chasing are relatively small, and if we just use sort of simple observational or quasi-experimental design, we may mislead ourselves by either seeing or not seeing effects that are real, by either seeing things that are not real or not seeing things that are real because of secular changes. We have much less understanding of confounders. I'd actually argue that there's probably a stronger argument about using sort of more observational designs within the biological systems of the human body than we have in the healthcare and organizational systems, because if you ask me to correct for case mix across a large observational study of many hospitals, I wouldn't even know what to think about correcting for. Now, I may be limited, but I think we don't have a good understanding of that. Whereas at least if we were sort of saying, let's look at the effects of different antihypertensives, I'd have a strong epidemiological and mechanistic perspective to start to develop hypotheses about what we might want to actually try and correct for. The final issue about why this is important is if we get it wrong and we say that something is effective and it isn't effective, and healthcare systems pick that up, there's a huge opportunity cost. Healthcare systems don't have a lot of resource for investing in this area. And if they start to do ineffective things, they're wasting the small amount of their budget, which is being devoted to quality and implementation. And so we really need to make sure we get it right. Here's an example of a trial that we did in Australia. There's a Cochrane review from the mid-90s that demonstrated that stroke units led to improvements in mortality and morbidity in patients with stroke, but often stroke units were rather a black box. This was a nursing-led study led by Sandy Middleton, who's a professor of nursing at the Australian Catholic University, and it aimed to try and optimize the management of fever, hypoglycemia, and swallowing dysfunction in the first 48 hours of a stroke. We randomized 19 stroke units to the intervention. And basically what we could demonstrate was, I don't know if you can read this, but basically there's about a 16% reduction in severe disability and death, but mainly severe disability at 3 months with patients treated in the intervention groups. So this was an example of improving the microprocess of care in a stroke unit by nursing led to a huge effect. I think we need to replicate this. I think that we were lucky. I think if we did it again, we would not get a 16% improvement, but I think we'd probably still get an improvement. But this basically demonstrates doing the right things right in the clinical environment can actually lead to very profound effects in terms of patient outcomes. Again, it highlights why this is a really important area of work to be done. And if we'd have done this not in a randomized controlled trial, I suspect people would have found many, many reasons to not believe what the result was. Okay, we need to replicate it. I don't know, I think we've probably got the most positive result we'll ever get. But actually, I think the study has internal validity. That effect was observed. But one of the challenges when you think about evaluation, one of the concerns are that randomized controlled trials only tell you one piece of the puzzle. So rigorous quantitative designs allow strong causal inference to be made about the effects of a program. Did A lead to B? And Shadish, Cook, and Campbell calls that the causal description. But they provide relatively little information about the mechanisms through which a program operates, so a causal explanation. How and why did A lead to B, which will actually help us start to think about the generalizability of the study findings. And so what I think we need to do if we're going to use randomized controlled trials as our method of looking at causal description, we also have to think about adding in a range of other forms of inquiry that allow us to explore causal explanation. And we can do this through design elements or process evaluations or also temporal evaluations. Did the benefit was there a delay in the start of the benefit of the intervention being seen? Did the intervention benefits decay over time? So we can start to build other forms of inquiry that actually allow us to make greater sense of this area. This is an example of a trial where we tested simple reminders on lab reports going back to family doctors said something like, in general, it's really dumb to do that test. In nice language. But this isn't a test that is particularly useful in primary care settings. Demonstrated that across 9 tests, we got about a 15% reduction in lab tests, which were largely uninformative or helpful in primary care. We hypothesized that basically this was likely to work through basically changes in attitudes and social norms, and through those changes in intentions. We measured after the study basically those theoretical constructs and could demonstrate that in the intervention groups it did look as though the behavior change was mediated through changes in intentions. So we built a model about how we thought the intervention worked, and then we tested, did it actually work in the way we thought it did? And in that setting, it did seem to do that. Good. Developing KT theory. Hopefully what you've got is this idea that this is a complex issue. And it's a complex issue that is multi-leveled, and also is a complex issue where there are multiple disciplinary perspectives that might be useful. And Ewan Fairley and Steve Shortell suggested there are 4 levels of intervention to improve the quality of healthcare. These are very similar to my barriers. We can intervene at these different areas. But different types of theory are going to be relevant to interventions at different levels. If we're interested in the individual health professional, then some of the psychology models or education models that I've talked about might be useful. But if we're interested in healthcare groups or teams, you might also want to add in more organizational sciences, more social psychology, small group process psychology. If you want to then get into the organizations providing healthcare, then I think you get much more into the mainstream management and organizational and business sciences. If we talk about the larger healthcare system, you're also going to bring in political theory and economic theory. And so if we want to make sense of this field, we're going to have to start to access and use theories from a very broad range of disciplinary perspectives. But unless we do that, we're not going to start to develop the principles that will allow us to think about how we as healthcare systems and healthcare organizations can improve the care that we've got. We've been particularly looking at the individual healthcare professional level. And in this study, we explored, I think, 10 different the predictive value of 10 different psychological theories to look at whether they predicted the behavior of prescribing antibiotics for upper respiratory tract infections. And we found that they performed moderately well. They performed probably not as well as they do when they look at our individual behaviors, but they still performed reasonably well. But I think in this area where it's non-emergent knowledge, most of the action is actually post-motivational. People know the evidence, they intend to do it, and actually we have much poorer models about what we do in that post-intentional space. I hesitate to put this up in Michigan because you know much more of this story than I do. But this, I think, is a very interesting paper from a methodological perspective. So Mary Dixon Woods is a sociologist in Leicester, and she made this a great observation that often when you've developed a quality improvement program, how it unfolds in the real world is often potentially different from how you thought it would work. And you also often learn about what was actually really important as part of that. So what Mary did in this project is that she interviewed Peter Provenos and other members of his research team to try and sort of say what was actually happening from their perspective, and started to identify a range of factors that they, as the research team, thought were important in terms of driving the success of the intervention. And she talked about this as developing an ex-post theory of the quality improvement program, of trying to maximize the learning from that. Now, we had a discussion yesterday that you could really enhance that if you're also doing interviews with the professionals and the managers who are also in the healthcare systems. So you're actually sort of trying to get all stakeholders involved in this venture to say, well, what was really going on? But using a very critical lens to try and learn a posterior what was happening in those sort of settings. And I think the method is actually really, really interesting and something we should be almost routinely trying to put in.